Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today we have with us Dr. Gurbakhash Kaur, who is assistant professor at one of the leading myeloma programs in the country, Icahn School of Medicine at Mount Sinai in New York. And she presented some of the data at the European Hematology Association meeting that was just concluded that caused a lot of attention and created quite a stir. So I'm glad to have her here to talk about her research. Welcome, Gurbaksh.
Thank you, Dr. Vij.
So this was a study of what we call Anitocabtagene in relapsed refractory myeloma, the Imagine-1 study. So for our audience, could you just give us a little primer on how this differs from the two currently commercially available CAR-Ts, Abecma and Carvykti?
Sounds good. So Anitocabtagene is also targeting BCMA like Carvykti and Abecma, but what is different about it is that it has a novel binding domain called the D domain. And the uniqueness of these D domains are that they're very stable. They bind to the target very efficiently, but also able to release very quickly. So what we think how that translates into clinical practice is that you're able to see deep and durable remissions with this CAR T without the toxicity.
So I understand that before the trial that you presented, there has been one other trial done and reported. So could you just, for the audience, tell us what we know about this drug so far?
So we were able to share the updated data follow-up of the phase 1 portion of the study, which demonstrated a median progression-free survival of 30.2 months in a heavily pretreated patient population. And then also we were able to see 79% of patients achieve a complete response or better. The median overall survival was not reached. And what was also unique was that the patients who had deep responses, their PFS was also longer by a couple of months, 34.3 months. It had similar efficacy and durability in terms of their remission, even in the high risk features. And you know what those are, right? The high risk EMD, high risk cytogenetics. And the key thing is that this, with the long-term follow-up, 38.1-month follow-up, we saw no non-icons related toxicities such as Parkinsonism, cranial nerve palsies, or Guillain-Barré in the study.
So now coming to the main presentation of the data that you got to present. So could you tell us about the trial here?
So this is your typical phase 2 study design of a CAR T study. In this study, we enrolled patients who had prior IMiD, PI, and CD38 targeted therapies already. They had to be refractory to their last line of therapy, and they had to have more than 3 or more prior lines of therapy. And the primary endpoint was overall response rate. And the key secondary endpoints were stringent CR or CR rates per 2016 IMWG criteria.
So how did the patients do on this study?
So 129 patients were enrolled, but 11 discontinued for the reasons that are highlighted on the slide, such as 4 withdrew their consent, 4 had disease progression, 1 was an investigator decision, 1 was no longer ineligible, and ultimately 117 patients were dosed with this. And all these patients, the data that we're presenting at EHA had a median follow-up of 12.6 months. And Anitocabtagene was successfully manufactured for 99% of the patients enrolled.
And what were the demographics of the patients enrolled?
So what you can see over here that there's a diverse age population that's enrolled onto the study. So ranging from 38 to 78, but notably 9% of the patients were 75 years and older, and 28% were 70 and older, with Black patients comprising 15% of the cohort, and Asian or others comprising 9% of the cohort. And 15% of the patients had extramedullary disease, and 38% had high-risk cytogenetics. So a sizable patient population with high-risk features And 100% were, as I said, refractory to their last line of therapy. 86% were triple refractory. 40% were penta-refractory. And to note is that 9% of the patients had outpatient administration of CAR T. So I think that is key to know. 75% of the patients received bridging therapy.
And so, what were the results?
So at a median follow-up of 12.6 months, the overall response rate was 97%, and the stringent CR rate was 68%. 70 out of the 75 patients were MRD negative at minimum 10 to the minus sensitivity. So that's a rate of 93%. And what you note is that the median time to first response and the median time to MRD negativity is 1 month. So response happens rather quickly, and you also get deep responses as well.
And what about the durability?
So the durability is that the estimated PFS 6 months was 91.9%, and the overall survival was 96.6%. The 12-month PFS rate is 79.3%, with an overall survival rate of 95.2%.
And how did it do for CRS?
So 85% of the patients, which is 99 out of 117 of patients, had CRS grade 1 or less, including 15% of the patients having no cytokine release syndrome. The median onset was 4 days, and it lasted about 2 days. And you can see on the slide that patients received tocilizumab, dexamethasone, the typical medication regimen that we use for commercial and non-commercial CAR Ts. And I do want to note that no prophylactic administration of tocilizumab or dexamethasone was done in this trial. Of the patients who either had no CRS or CRS that resolved by less than or 7 days, that was about 80%. And 97% of the patients had their CRS or no CRS by 10 days. And we can go into, I believe, the next slide, which is neurotoxicity. Right? I think we
Yes.
went ahead by one slide. Sorry.
Let me see.
Yeah, it moved fast. Okay, so in terms of neurotoxicity, 8% of the patients had ICANS of any grade, and all cases resolved. And so you can see over here, 92% of the patients experienced no ICANS. There was only one event example, 1% of the patients experienced grade 3. Like I said, there was no delayed or non-ICANS neurotoxicities that were observed. And that includes no Parkinsonism, no cranial nerve palsies, and no Guillain-Barré. And similarly, as I highlighted before, even in the phase 1, where you have a 38-month follow-up, there was none of these delayed neurotoxicities were observed over there as well. And the median onset of ICANS was about 7 days, and it lasted about 4 days.
And any other side effects to mention?
No, I think you get this pretty standard cytopenias that you see with most CAR Ts related to lymphodepletion and subsequently to CAR T. I do want to note that there was no cases of immune effector cell associated enterocolitis. This is something that's sort of coming into light recently. So we looked at this thoroughly in the study.
So, what are your key takeaways for the audience from this study?
So the key takeaway is that Anitocabtagene is a novel synthetic compact and utilizes a novel synthetic compact and stable D domain binder, which allows for high transduction efficiency, CAR positivity, and ultimately CAR density on the T cell surface. It has a high binding rate but also a fast off rate. It demonstrates deep and durable remissions at a median follow-up of 12.6 months, so overall response rates of 97%, with CR rates of 68%. The median PFS and overall survival were not reached. The time to response was rather quick, especially MRD. It was about 1 month. The anito-cel safety profile is very predictable and manageable. 92% of the patients did not experience ICANS, and only 85% of the patients had either no CRS or a max grade 1 CRS. And so far, more than 150 patients have been dosed across the phase 1 and phase 2 anito-cel programs. And we did not observe any non-ICANS neurotoxicities and no immune effector cell associated enterocolitis. So the takeaway point is that we have a very effective CAR T.
Definitely, no doubt about it. So, it seems like this is moving into now phase 3 studies.
Yes, the Imagine 3 is a global phase 3 clinical trial in patients who have relapsed myeloma in 1 to 3 prior lines of therapy, and then it's enrolling currently.
So when does our patient population get to use this drug commercially?
So from what I hear in out there, maybe possibly next summer. I'm not sure entirely. You know how this regulatory stuff happens. All of us don't really know, but I have a feeling that sometime next year we should be able to have access to this.
Well, that is very exciting, and I see that you have a product that seems to be as good as what we have best in class and perhaps got less side effects. Is that a fair assumption?
Yes, I think that is a very good assessment of the situation.
Well, I hope that you and your colleagues continue to work on this, and hopefully, I can have you back to give us updates on this and other issues in the future.
Sounds good. Thank you so much for having me. It's been a pleasure to have this conversation about Anito Cell with you.
Thank you very much for being on. Thank you.